Thanks so much, Alejo, and recording in progress. And thanks for those of you who are coming. It's a pretty small group, so I'm happy to make it more of a conversation if you're willing. I'll show a couple slides, but I don't really want to get I don't want to bore you with the PowerPoint too much. But as Alejo said, we have a laboratory in the city of Arequipa, it's just an old house that we rented maybe in 2005 or so, and we made it into a lab. And but I'm going to go a little bit before the founding of the laboratory. I got to Arequipa in 2004, before I came to Penn, and I was a graduate student at Emory, and I had a cubicle at the CDC. That's probably my official title at CDC, guy with cubicle. And I was living in Peru though. I moved to Peru in 2001, and I'd fly up to Atlanta, take my classes, fly back to Peru. And I spent 3 years trying to get research going. And finally I saw an article in the newspaper, and it was all wrong. It said something like, "Now de Chagas avanzan la ciudad blanca," which is Arequipa, the white city. And then the rest of it was wrong. It said something like the bacteria, Trypanosoma infestans. It's actually a parasite, and it's Trypanosoma cruzi. Like the whole article was terrible. But I cut it out, and I was working with a professor named Bob Gilman, who was from Hopkins. And I'd come to Peru, and he had a training grant, and I'm not sure what the grant said, but what he did with it was he would basically tell students to come down to Peru. And then he when I got there, he said, "Oh, great, glad you made it. Who are you?" Because he had totally forgotten all about me, which was a good policy, because the students who showed up were the ones that he wanted to support. And then he said, "I'll give you this training grant because I can only give it to American citizens." That's how NIH works. They'll give training grants mainly to American citizens, except for the Fogarty Center. And it gave you like $6,000. And he said, take $100 you have to pay rent in the student house, take another $100 to live, and then use the rest to do a research project. So I had this small chunk of money, and I said, "Okay, I want to work on Chagas disease." And I guess we're recording this, so he might disagree with me, but Bob said, "You're too late. It's already gone," because he was in Lima. And in Lima, they were unaware of the problem of Chagas disease in Arequipa, because Arequipa is a kind of a free state that's declared independence from Peru. So I spent 2 or 3 years working on TB, because that's the biggest problem in Lima. But it wasn't what I really wanted to do. I like bugs. I'm an ecologist. So when this article came out in the newspaper, I cut it out. And Karen Byrne, who was an actual CDC employee, an epidemiologist in the Division of Parasitic Diseases, was in Lima. She also worked with Bob en route to her study site where she worked on leishmaniasis. I'm not sure exactly where, somewhere probably in the jungle, and her site was flooded. So I grabbed her and I said, "Come with me to Arequipa. Let's go see what's going on with Chagas." And she was like, "Oh, I've never been to Arequipa." Fine. So we flew to Arequipa with our CDC hats on, which was precisely what they told us not to do. And we got there, and in the article it mentioned a professor at the university. Actually, it didn't mention him, but we called someone that was in the article who put us in touch with Dr. Eliasser Cordova. And Dr. Cordova became my actual mentor. He was a professor of biology in the Universidad Nacional San Agustin, so not the university we ended up partnering with. And I got to meet him, and he took me to meet, and we also went to meet with the Ministry of Health. And then Karen flew back to CDC in Atlanta, and I stayed. And I just stayed and stayed and stayed. And I think the partnership really got going because I didn't leave. I spent 5 months, and it was a lot of downtime. I sat through a lot of meetings, but I got to know people. I started going out on spraying houses with the field team. And I spent my days spraying houses and catching bugs, and I'd bring them back to Dr. Cordova's laboratory in UNSA, San Agustin, and we'd squeeze the poop out of the bugs and look for T. cruzi. And so I did that for months and months. And I'll show you a little bit of what a little more context. So we were kind of a little blip on a massive campaign known as the Southern Kona Initiative, which originally was to eliminate Triatom infestans, which we call the chirimacha in Peru. And this has been one of the most effective public health campaigns of the recent decades. This is the distribution of the bug in maybe 1991. And this was the distribution more or less when I got to Peru in the mid 2000s. So this is the Chaco, which is an extremely poor and difficult, economically distressed area where the bug is also endemic. It's originally from that region, as far as we know, as far as I know, and that they've been unsuccessful in eliminating the bug from this area. And then this little blip in southern Peru is Arequipa, where the bug became an urban problem. So this initiative was originally to eliminate the bug, which I understood as get rid of the bug, except in the few spots in the world where we knew it existed in rock piles feeding off of wild rodents. But the aims of this initiative shifted there was no announcement, but they shifted subtly to eliminate transmission of the parasite T. cruzi by Triatom infestans. So that didn't seem like a big deal, but then they needed a metric. And this was all coming from the Pan American Health Organization. So they needed a metric because they wanted to be able to declare states and countries free of transmission of Chagas disease. And the metric that they landed on was keeping the prevalence in children 5 and under below 2%. So even though this subtle shift, just a change in wording, eliminating the bug to eliminating transmission by the bug, ended up being a huge shift. So now we were no longer trying to get rid of the bug, but rather keep prevalence in kids 5 and under below 2%. And that was, that shifting sands approach was very difficult for us because we probably had prevalence in kids under 5 below 2% from the beginning. Prevalence depends where you draw the lines and the boundaries. And if you drew the lines around the whole city of Arequipa, much of it had no Chagas disease and prevalence would have been low. So we, based on this metric, 4 countries were declared free of transmission: Uruguay, Chile, Brazil, and Paraguay. And then the Chaco region and southern Peru was lagging behind. So we were starting late. And the reason everything started in Peru was a death. A baby died of acute Chagas disease. And usually if you see a case of acute Chagas disease, that means there's 1,000 you're not seeing. It's rarely diagnosed. And although it's fatal, you rarely know about it. So this baby died in the district of Hunter, which I'm showing here, which is kind of, it's an economically diverse district. The hills here are fairly poor, mainly populated by newer immigrants to the city. But some of these parts of Hunter are middle class. And there's a lot of press around the death of this child. And that kind of started a process of evaluating the dispersion of the vector in the city, which was a lot. By the time this child died, the bug was all over the city. And luckily, the PAHO representative in Peru at the time was a doctor named Ruben Figueroa, and he had grown up in northern Argentina, in Salta, which was an area endemic for Chagas disease. And he found out about the Chagas problem, and he was very aware of what can happen if you let it go unchecked. So he came to Arequipa, and he negotiated a funding deal with the Canadian International Development Agency. So money was coming from Canada through PAHO to Peru, and that money financed the insecticide treatment of this district Hunter. And that included communication, that included paying sprayers. I'm not sure who paid for the insecticide, but it was a very well, there was some growing pains, but once I should say, I'll skip to the Nets district. So Hunter was sprayed in 2003, and I'm showing in red the infested houses. There were a lot of bugs in that district. But there were more bugs in this district over here. This is Tiabaya and Sachaca, 2 districts. And I arrived in Arequipa when I saw that article in 2004. And there was this game of chicken going on where PAHO and the Canadians had said, okay, we sprayed the first district. Now you, Ministry of Health, are supposed to take over the campaign. And the Ministry of Health said, well, we don't have the money. So the Canadians came through with another more support. And when I got there in 2004, like there was communication, pictures of chirimachas on walls all over the city. You could get into a taxi and the driver would know about Chagas disease. I know, because I would always ask. You could talk to like little kids in the plaza and they knew about Chagas disease. It was very much in everyone's mind. And that stopped at some point. The communication money stopped probably after 2004, and it's amazing how quickly people forget. When I would ask taxi drivers in 2006 or 7, no one knew anything about it. Kids had no idea. It's very that always struck me, how quickly the communication wears off. So we sprayed this area, and this is a hill called Guadalupe. And as I was going around spraying all these hills, and I said, I want that hill. I said, I want to be there with people to do a more careful study on that hill. And I had a lot of support from Jenica Pastor, who was, I think her job was administrative assistant to the head of. She ran everything. She was very efficient. And then when Ruben Figueroa came, he basically, his strategy, he yelled a lot. He would say, you need to spray. And that kind of worked, because there was a bit of not apathy, but kind of like a feeling of, the bugs are all over the city. It wasn't super urgent, I would say. And it took a little bit of, I think Ruben really lit a fire under everyone. It wasn't that people didn't want to control Chagas disease. It was just, that it wasn't, it took a little bit of Ruben yelling. So the original partnership, I guess, was, getting back to how this partnership grew, was between the CDC and the Ministry of Health in Arequipa. And that partnership consisted of a letter from my boss that I wrote, of course, in Spanish badly, that I was told translated to something like, you have been gifted to the Arequipa Ministry of Health for a couple of years or something like that. They used to tease me about this letter. So we had this kind of government to government informal agreement, and the CDC, in those days in the CDC, we had this thing called glassware, where you could just order stuff. You could just order tubes and syringes. And so my boss let me use the glassware, and it was all kind of like, no one kept accounting. So we got all these supplies from CDC, shipped them through NAMRID, which is the Navy Infectious Disease Research Office in Lima, and they get to use the APO. They get to use the Army Post Office. So it was easy to get stuff. That was the extent of the partnership. And then this larger partnership was Canadians providing funds through Pan American Health Organization to the Ministry of Health in Arequipa. So Lima, the Ministry of Health of Lima was not super involved. And then it was run, a lot by people who were maybe a little lower on the totem pole, such as Jenica, and then Fernando Malaga, who at the time was the head of a spray brigade, who's now in charge of the whole program. So I was going to the field with the spray brigade. Fernando was, making sure the spray brigade was spraying, and Jenica was doing a lot of the coordinations. And we sprayed Tiabaya, and then we started going counterclockwise through the city. You can see we sprayed until 2009, and it was always a game of chicken. The Canadians kept saying, okay, we sprayed this district, now we're leaving, you have to pay for it. And the in Peru, they said, well, we don't have the money. And if we stop spraying now, the bugs are going to come back, from this spot that we didn't spray into the spot that we just sprayed. So we're going to lose all this advance. And I wasn't involved in all these conversations, but that was the sense I got, this game of chicken. And finally, the Canadians left, and it was cold turkey. Everyone was fired. It was just like one day to the next, the money dried up. We didn't have any insecticide. And, I guess you can do a lot of public health theory about this. And, I guess the model is always, the people come from up north, and they come and they tell you what to do, and they provide all this guidance, and then they leave, and you're supposed to pick it up. And that's a colonial model, right? Like it's not super realistic. But I'll show it. I guess in the end it worked out. So they left, and at that time, so they had one person working in Dr. Cordova's lab, examining all the bugs that came out of this campaign. So you can see all those red houses. This is an enormous number of houses, and you had to check all the bugs for T. cruzi. It was in the protocol, and I'm glad they did that. So I said, okay, I'll hire her. And I had at that time, I guess we first got a grant. We got some sort of, we had these fellowships. So we had that money. I had my own graduate fellowship, and we got like 50,000 off of some other grant that Bob had. And then we got a small grant from the WHO. So we had a little bit of money. So I basically started hiring people who were being fired after the Canadian money left. And for a couple of years, we had no insecticide, and we did a lot of entomological surveys. I won't go into those. And then eventually, the campaign started again, but you can see it jumped, and it jumped up to this area. This is a wealthier district, the district of Kaima. This part of the district wasn't wealthy, but the district as a whole was wealthier, and they were able to pay some of the costs of the campaign. I think they hired the personnel, and then the Ministry of Health got the insecticide. It was some deal like that. So they got sprayed in 2012. And then eventually we were able to fill in the unsprayed areas again. It became much more of a negotiation with funds from the district. At some point, probably around here, Peru decentralized its health system, which meant that the powers that were in the regional office of the Ministry of Health were taken and given to the Red de Salud, the health network. And as from my understanding, these just look like two exactly parallel systems, and all the power was taken away from Fernando, who I worked with, and given to Andy. That was what it boiled down to. So Andy was now the boss of all the sprayers. But Fernando was still in charge of the strategy. So there was this kind of a mess in coordinating the campaign, and that kept going for quite a while. Maybe I'm giving too much detail, but in the end of the day, we finished the campaign, and we sprayed 80,000 houses about, and you can see in red, a lot of those were infested. But there are also large parts of the city, the center, we never had any bugs, and the very periphery, we never had any bugs, which was interesting. Some of the poorest houses in the city were always bug-free. So let me go back to how we started. So while we were doing this, all the bugs would come to my lab, to the lab that became the UPenn UPCH zoonotic disease lab, and that happened because in maybe 2004 or 5, there's a grant, a tropical medicine research center grant. So it's if you're into grants, it's like it's a P grant. It's like 2 R01s. It's these big grants. And for years, some other researchers at Cayetano and Bob had these grants to work on cysticercosis or other diseases. And in 2004, this grant comes up every 5 years. So I guess it was somewhere around 2004, 2005. Someone in the NIH decided that they were going to focus on neglected tropical diseases. And they said specifically Chagas disease, leishmaniasis, and maybe one other. So all of a sudden, we became really important because we were honestly kind of a small group of, there were me, a US medical student, and a Peruvian fifth-year medical student doing a year after studies to do research. And then, we'd hired 4 bug collectors. So we were kind of a small outfit, but all of a sudden we became really important because the people who had this grant had to write it on Chagas disease. And I was still a grad student. So, but I wrote the grant. I wrote half of the grant. Karen Byrne wrote the other half, essentially. I wrote the part about bugs, and Karen wrote a clinical part. And Bob Gilman, our boss, kind of knew what we had to do and got all the pieces. We had a qualitative team, and we had this, it was a huge administrative team. And when we went to the University San Agustin, where we worked, where Dr. Cordova's lab was, and we needed them to sign some papers to get a Duns and Bradstreet number. And this is a racket. So in order to get a grant in the US, you have to have this number from Duns and Bradstreet. As far as I understand, that corporation, whatever it is, exists solely to sell these numbers to the government. And but you can't get a grant without it. So we had a meeting, or rather, Bob had a meeting with someone at the local university, and they wouldn't sign this piece of paper in English that for some bizarre number. You can imagine why someone would be reticent to sign a paper like that. And I think they also were looking for more from the U.S. university. In this case, it was Hopkins. This is before Penn. I think they wanted Hopkins to take students and things like that. But at that point, the people involved in the grant just wanted this piece of paper signed so that they could submit the grant and then get to work. So Bob went to Cayetano, and this was kind of hard on me because I had been working with Dr. Cordova in his lab and collaborating very closely with him, and wanted to keep collaborating very closely with him. But and it wasn't just this number. You also needed someone with a strong CV to be the PI of this grant. So the PI of these grants, there's a local PI and a US PI. And Dr. Cordova knew more about Chagas disease than I think anyone alive. Chagas disease in Arequipa, I should say. He was just amazing. And but he didn't have very many publications because if you're a professor in a public university in Peru, you don't even have the funds to pay the publication costs. So he didn't have a CV that would do well at the NIH. And I think for that reason, Bob went to Cayetano. And Cayetano is a private university in Lima, and they know all about NIH, and they have a Duns and Bradstreet number and all this other setup to do research. And so Bob, there's a wonderful. So both Dr. Cordova and Dr. Nakira, who became the PI of this grant, passed away recently. Dr. Nakira was he was an amazing person. He was the head of the INS, which is the Peruvian NIH, for many years. But he he grew up in Arequipa, and he had published on Chagas in I think there's 1959 was one of his papers. He'd been working on Chagas as a young physician and researcher. Then had a career in Lima, which was political as well as scientific. And there's no more popular head of a government agency, I think, in the world. He was loved by everyone, and everyone was his student. Everyone in the government had him as a professor at some point. So he was truly wonderful, and he had finished his term as head of the NIH and was kind of emeritus, I guess. So I guess we pulled him out of retirement to be the PI of this massive grant, and we won the grant, which was which was, was kind of amazing. I think we had 1.5 papers written on Chagas and Arequipa at the time. But it was such a compelling system. The Chagas disease in a city, and how do you control a bug? How do you deal with all the spatial control problems in the city? So I think we were able to write a compelling grant, and then we had Cayetano, CDC, and Hopkins, and other collaborators. So we got this grant, and then for me, I think things went downhill, right? Because before then, it was this kind of scrappy partnership that was just a few people, and it was a lot of fun. We had this, we'd get like $10,000 here, $25,000 here, $50,000. It was like a big deal, and we do these kind of small studies. We did this funny thing with guinea pig bed nets, where we got bed nets. Again, my boss at CDC helped me get those, and we'd put those over guinea pig enclosures and see if we could prevent Chagas to guinea pigs. We did these, fairly small things that we could do kind of under the radar, and with the collaboration of the Ministry of Health. And it was fun that we'd have this. I remember one of the, I guess my postdoc project was Fernando, or no, someone else that was asking, all right, where do we spray nets? And you look at this whole city and you're like, oh, that's a really interesting spatial problem. And then, 3 years later, we'd come back with an answer when it was already too late. Anyway, I digress. But all of a sudden there was an infusion of money, and a lot of money. And that's when we rented the house. Before, we had been working out of where we lived. We had a student house with a little garden, so that's where we had all our supplies and stuff. And then all of a sudden, the NIH really said, it's a center grant, you have to have a physical center. So we rented this pretty big house near the Ministry of Health, and made it into a wet lab and an insectary. So we were raising chirimachas to do entomological studies. And we were also keeping strains of the parasite alive. So we had a lot of freezers, and then we had kind of a dry lab for all the data, which computation. And we started doing, we started having to do stuff in the grant, which became a little less fun, but it just became a different thing. And so let me finish so we did these studies of school children and population-based studies. And then we did this target screening idea, where we took all that data, all the bug data that we had, and we knew where the bugs with parasites were. And we tried to aim our serological testing around the hotspots of parasites. Didn't totally work out the way we envisioned. And then we did this transect, and that's when we started really studying urbanization specifically. We did these kind of ecological transects of the city to understand how the growth of the city affected the spread of the insect. So this was the first hill, Guadalupe. I won't go through all this stuff, but we also started looking at history, right? All the emergence of this disease has its roots in political changes and that affected people, that brought people. You can see on the top here is just how this hillside became populated over the years. And a lot of it started after Velasco, who instituted agrarian reform, and that led to a lot of migration to the city. That wasn't the idea. It was kind of an unintended consequence of this agrarian reform. And then this is a famous photo of the head of the Shining Path, Abimab Guzman, when he was captured. And he grew up not far from this hillside. And partially for that reason, Arequipa was something of a safe haven during the Shining Path years. And a lot of people flooded in from rural areas to Arequipa. So you can see a lot of growth at that time. And then people continue to settle on this hillside. I'll talk a little bit, well, this is jumping a lot of years. So Penn's relationship with Cayetano existed before I came to Penn. I came in 2010, and Jack Ludmere, who was a professor in the med school, was from Peru and had gone to Cayetano, and he had started this relationship. And I guess I was partially recruited to Penn to strengthen that relationship. but didn't always fit into everyone's goals. And I think, to be blunt, I think Cayetano, they're a private university, and one of their selling points is that students who go to medical school at Cayetano are often able to come to the US to do residencies. So their main, when they're looking for partnerships, they wanted to make sure they could send their students up to Penn to do rotations, which would eventually lead to letters to make it easier for them to do residencies and complete the steps. And Penn, I don't know what our motivations are. I think, we have a lot of students who want to do summer trips, and then we also have more of a research push. And then, I was in Arequipa, kind of not sure how exactly our lab fit into this. And so we kind of, I guess we kind of made ourselves the Penn Cayetano Zoonotic Disease Lab. And we were purely funded off of our own NIH grants. So we were a little bit, I'm not sure we were central to the goals of each institution, but it worked out. And I think, I'll think talk more about that after that. I do want to show that what we're doing now. This is an immune system for the city. So this is kind of the culmination of all those years of catching bugs with the Ministry of Health. So the spray campaign really completed in about 2016. And then the bugs were pretty much gone. They weren't totally gone. They would pop up every now and again, but they were gone. And that meant that all the money was gone. So the funds that had been supplied at this point kind of haphazardly for personnel were gone. So we had at the height, we probably had 35 sprayers. And so we had 7 brigades, each had a head of a brigade, and there was a biologist for every couple brigades. And then we had communication specialists. It was a big campaign, and that was gone. And a number of the sprayers were able to get permanent positions in health centers. So they were kind of scattered across the city, and one of their roles was to continue to do Chagas surveillance, but that was one of maybe 25 things they were supposed to do. So they're also in charge of surveying for rabies. They're also in charge of checking the water, making sure the water is okay. They're also in charge of who knows how many other things. And then the reality is these centers are understaffed, and this is pre-COVID. And so a lot of times they were working the register, triaging people. These health centers are doing a million things. So there wasn't any funds for surveillance, and like I said, PAHO had pretty much pieced out. So PAHO representatives rotate countries. So at that time it was, I think, 3 years. So after Ruben Figueroa moved on, we got a guy from Cuba who used to call chirimaches chimichangas. Obviously he knew what they were, but he really could care less about Chagas disease. He had other priorities, and there were other things to worry about. And as the bugs went away, the worry went away. So we kind of filled in on surveillance, and we were lucky to have all those data. So we had 12 years of spray data, which is called the attack phase. So we knew which houses had been infested. We knew which houses had not participated in the spray program. And both of these were, as you can imagine, kind of risk factors for bugs coming back. And then we had 10 years of fairly haphazard surveillance, which was either when a technician happened to check a house or two, usually because someone asked them to, or our team, because we did all these different studies. We'd go and survey 300 there. So we put this all together, and this was kind of a beautiful collaboration, with the team on the ground, and then a PhD student, Erica Billig-Rose, who did a lot of the statistical analysis to try to give a kind of a risk map, taking into account the effect of streets. The bugs really do not like crossing streets. So she did her thesis on this. And we started with very complicated models. And we even put some of them in the field. We had this reversible jump Monte Carlo thing where you try to make inference on unseen infestations based on the observations of real infestations. And it was beautiful math. And then we had our technicians, her model would send down the houses to go to on Monday. And, they'd go to these houses. And it was, and then on Tuesday, it'd update overnight, and then it would send them like back to some houses that were pretty near the houses they'd gone Monday, and then to other houses far away. So they were kind of just going like this up and down this hillside based on this very complicated risk model. And I kind of joked that they really hated Erica because they were climbing up and down this hill when it could have very easily been done in a much more efficient way. And so we really started thinking about giving the limits of optimization and how to give the technicians, let them use their own brains when they're in the field and plan their own routes to some degree. And so that led to kind of rethinking the whole idea. So this is something I've been working on this idea for, I think it's been 10 years since I had this idea. I remember having the idea, in Peru. And I always say, never plan studies in the US for Peru, and never write grants in Peru. Because if you plan a study from up here, you end up with something like we had with Erica. It's super optimized, super cool. And then when you're on the hill, you're like, this is so stupid. And then the opposite is when you're down in Peru trying to write a super important, and then you come back here and you're like, no one gives a damn. Like the things that are important are very context dependent, to put it mildly. So this idea grew out of the surveillance issue in Peru, and it really it also is like historical routes. The conventional surveillance for vector-borne diseases it comes out of the military, and you can trace this back to the U.S. invasion of Cuba. Part of which was to stop yellow fever from coming up to New Orleans and Philly and Boston and New York every so often. It was the typical idea of let's deal with the problem at its source. You can see the same idea with many other U.S. ideas. So the military went into Cuba, and the studies that really proved the hypothesis by a Cuban physician, Carlos Finlay, who actually did his med school in Philly, but not at Penn. He had shown in he had figured out in 1880 something that Aedes aegypti was carrying yellow fever. But so the U.S. military proved his theory, and then they started doing vector control, and it was top down, as you can imagine, and it was very effective. And they were able to eliminate yellow fever from Cuba. And that model has stayed with us. So much vector control comes out of the military. And for Chagas, it's kind of served us well. So Chile eliminated transmission of Chagas by the Chirimacha under Pinochet. And the joke that Dr. Cordova often said was when they came to spray houses in Chile, you had the sprayer, and then you had the carabinero, which is Pinochet's police force. And participation rates were like 110%, right? Because everyone had to let people in to spray their house. When that model came to Peru, which say what you will about the Peruvian government, it is not a military, it's not a strong central government at all. It kind of broke down, and we had a lot of problems with participation. And when it came to surveillance, we were still doing it the military way, and that you can see here in my graphic that we made for the grant. The Ministry of Health and us to some extent were the generals, and we had our soldiers who were our vector control technicians, and the infested houses were the enemy. And we were sending our soldiers out to eliminate the enemy. And when we used community health workers, they were informants. They were supposed to rat out their neighbors that had bugs so the soldiers could come and get rid of the bugs. And so right now we've taken all that beautiful modeling stuff and we've created one app for vector technicians to use that's called Puntos Azules for obvious reasons. And the soldiers are told to go to these houses, these blue houses. And if no one's home at that blue house, another house turns blue nearby. And it's been in use, and people kind of like this. The technicians kind of like having these blue houses that they need to go to. And I should say before this, and the technicians who are assigned to each area, we have maps of where they went, if they went at all. And you'll just see this little cluster of surveillance activities right around the health posts where they work. And then you'll see another cluster kind of near where they live. Like you can see there's totally, because they're working on quotas. So they're just going to the easiest houses to get to, not paying any attention to the risk of infestation in the area. I'm not sure why that moves. So the immune model, this is what I've been pitching for years, that changing the paradigm of vector control to the immune system, because it works across scales. The same system that protects a mouse also protects a moose. I was giving a talk to Peruvian Society of Infectious Disease yesterday, and I tried to say that in Spanish. It's like, how the hell do you say moose? But didn't translate that well. It also it's flexible to shifting aims, and we've been dealing with shifting aims a lot. And it integrates the active and passive surveillance. That was really the key. And then the other key was that it regulates the size and duration of control through feedback. Like the immune system, if there's a lot of pathogen, it makes a bigger response. And if there's a little pathogen, a small response. That's not how surveillance has worked traditionally. So here's our dream for the immune system for the city. And it was very centered on community health workers. And they were our CD4 positive T helper cells. They're searching the environment. And if they find an infested house, they clonally expand by recruiting other friends in their neighborhood to serve as vector control community health workers. And then we have a little WhatsApp network among this group of people in an area where we have infestation. And then they communicate with the CD8 positive T cells, who are our vector control personnel. And they also roam through the environment, but we don't tell them where to go. T cells, it's not like the thymus tells T cells where to go. The T cells have information. They have gradients of stuff that they follow, but they're autonomous in their search. And that's what we're doing with our control personnel. We give them the risk maps, but we let them search the environment. And while they're searching that, they're communicating with community health workers. And then the biggest thing is the infested households aren't the enemy, they're antigen presenting cells. And so a big change we've done, and this has been very hard with the quota system the Ministry of Health has, is we tell our personnel, you don't have to get inside the house. Like T cells don't go inside other somatic cells looking for pathogens. You're trying to elicit the report of the bug. So it's much more knocking on doors, talking to people, leaving folders, leaving phone numbers, WhatsApp numbers. And this grant started comparing these two approaches in January 2020, and immediately, well, we had a couple months before we got shut down. And the first thing we learned, and I think we knew this beforehand, is that community health workers, it's such an ideology. So the idea is that these unpaid people are somehow going to solve all our problems. And literally, this is the menu of things that a community health worker is responsible for asking their neighbors about. And it reminds me of one of those football coaches things. There's 54 things, everything from like bad oral hygiene to are your kids getting vitamin A, or is there suicide in the neighborhood? It's all over the place. And here we are, we're number 37. So the cherry matcha is on there. But it's ridiculous to think that these unpaid people are going to be able to survey for 54 things. So, we knew that was a bit of a myth going into it. And with the pandemic, community health workers, it just stopped. If anyone had any thoughts that, community health workers are going to help with vaccination efforts or help with letting the Ministry of Health know when there's cases, that did not happen. It was totally dead, the whole system, what there was of it. So Laura Tamayo, a student of mine, who did her master's at Cayetano, started Alerta Chirimacha. So we moved this all onto the web because that's all we could do for many, many months. And this helped us in some ways because the ministry was always a little reticent to allow people to report the bugs. They required that people catch a bug in a plastic bag and bring it to a health post before they will respond to the report. And that comes from that same military thing where the infested houses are the enemy. They don't trust people. There's this idea that, oh, people just want their houses sprayed for ants. And so they're lying about having chirimacha, so the ministry has to come and spray for ants. In 18 years in Arequipa, I can tell you that the number of houses who want the Ministry of Health to come and spray for ants, it's got to be zero. No one wants this. It's a total myth, but this distrust is built into the system. So they require this. So you can imagine, to talk about barriers to health, right? You have to catch this deadly bug in a plastic bag and then take it to your nearest health post. And then when people show up with bags in the health posts with bugs, like, we don't know how many times out of 10, but a lot of times out of 10, that bag gets thrown in the trash. It's not it's very rare that we actually get a report and are told to go, because we're actually in charge of going to the houses now. We took over the activities. So we now go and search the houses and spray them when there's report. So we moved this to Facebook and and WhatsApp especially, and it's been extremely useful. And we still do we still use the immune idea that when we get a report, we use targeted Facebook ads in a radius around the report. And then we also just go and put it up on bodegas in the area. But we only do it for 3 months. The immune system isn't always on. So when we get a report, we do this 3 months. It's all over Facebook in that neighborhood. It's on all the bodegas in the neighborhood, and everyone gets a little letter under their door, which I assume most people will crumple up or stomp on. But it has a WhatsApp number, and then people start writing. And it's beautiful because people, we've gotten, it was 192 reports through Facebook, and most of them will send a picture, and 182 of them were other bugs. And Laura responds very, amazingly, saying, "Oh, this is actually this bug," and tells them what it is. It's not going to hurt you or your children. And so it provides a lot of relief to people who are scared. And then for the 8 that were actual chirimachas, we start this whole system, and then we find secondary infestation sometimes. Let me get the question. So Megan asks, thanks for illuminating for us about your long-term partnership, Mike. Beyond new discoveries for Chagas, there seems to be lots of following skill set development for a range of research and supporting personnel. What do you think Peruvian partners value the most about your partnership? So like I said, I think they value, so yeah, how do I answer that? So Peruvian partners is a bunch of different things. I think the Ministry of Health in Arequipa, we're more flexible with funds. So we're more agile when they need to hire someone, but they can't because of the hiring process, we can step in. When they need a new computer, we can get the computer. I don't think the research is really super highly valued. And part of that is because they have real research questions, but it always takes us too long to answer them. But so under COVID, they couldn't do Chagas surveillance at all, but we had 8 people. And so we were able to take over the surveillance and spray activities. So our ability to provide personnel, I think that's really what our biggest asset is. And the research is, I think, fun, but that's not it's not the case that like, oh, we're bringing some sort of knowledge that's, helping on this problem. It's more, oh, you can hire staff. Oh, cool. They like, everyone likes the app. Like, yeah, it's not everyone. Some of the sprayers say, oh, I just look at the house and I know if it's high risk, which, if you've been to Peru, the facades of houses can look very different than the insides of houses. And, there's also a lot of biases in that approach. So yeah, I think the app and whatever makes their lives easier is probably this. So then the university in Lima, they hadn't sent students to our lab in Arequipa And so I had very little, in the past, very little real educational contact with them until we started this parallel plagues course, where we have students from Cayetano and students from here together on the same course. And that was so much fun. And that, I think, I think that's provided the educational value, and also the, a much more fun way for everyone to work together on projects. And then, the ability for their students to come and do rotations in clinical rotations at Penn is a big selling point for the university. So that's always been a big thing that they want.
Mike, I just want to jump in here real quick. We have about 8 minutes or so left until 10 o'clock, just to give you a time.
Yeah, well, I can finish, but if anyone has other questions, and oh, hi, Cesar, you're on there too. So Cesar teaches the parallel plagues course in Peru. I've been thinking a lot about sustainability, and there's this wonderful essay on non-scalability that kind of talks about, scalability is the ability to expand and expand without rethinking basic elements. And there's a lot of bad things about that. It makes you only see the scalable parts of the world. And I think that's true for sustainability too. We're asking that there's some system is just going to expand and persist through time without rethinking it. And so I often get the question, what happens when you leave? And I think about that a lot. And I think, I don't think that's the right question, because, you can't leave. You can't, this idea that you come, put in place some system that is sustainable and it just keeps going, or it's picked up by the Ministry of Health. When the Ministry of Health can't hire the personnel they need to do something, it's unfair. And I think that we as a university have an obligation to keep it up. We came down, I profited on all this research. My career has been built on all this work on Chagas. Penn has profited on all the grants, and we owe it to make sure that the system stays in place, rather than to think that we can leave and it'll be adopted and run on its own. So I'll oops, that's not in the presentation. I'll end just thanking everyone in Peru, especially Dr. Cordova and Dr. Nakira and Dr. Gilman, who were really the heart of getting this whole thing running, and all the students in Peru and the US.
Thank you very much, Mike, for that presentation. I had known, some about your work, but this was really informative for myself, and I'm sure for others who joined to really understand the whole context of how, your existing partnership was developed, and how it started, and, from humble roots to something, a little bit larger and more complex. So thank you for your presentation. Thank you. So we have here about 6 minutes or so. I'll open it up to the rest of the participants. You can either raise your hand or put in a question in the Q&A box located at the bottom of your screen. Does anybody have any questions for Mike? If no one else has questions, I have one, Mike. So you touched a little bit on the sustainability aspect, and you kind of answered your thoughts on that. What do you envision being, because there is this push in global health to be sustainable and to involve more of the partners, and have them taking a leading role. How do you envision that playing out in terms of funding, as well as your role and Penn's role? More so, to lead this, or can you envision some type of mechanism that, our Peruvian partners are able to take the lead and, conduct this research and work?
So Ricardo's not on here, so I can throw on him, but so Ricardo Castillo just got a grant for rabies that's going to keep our center going for the next 5 years. And so he's Peruvian, but he's now Penn faculty. And Valerie Pastaldano, who's the third PI, is Peruvian and Tulane faculty, but lives in Peru. And then, our whole staff is Peruvian. And so now we have 3 PhD students so 2 are doing their PhD at Cayetano. One's doing her master's at Cayetano, and just trying to integrate more so that the education stays. And then, during COVID, we lost our whole wet lab to the Ministry of Health because they could do PCR. And, the PCR never helped us any. We trained everyone to do PCR, and then they went and did the COVID testing in Arequipa. We lost our data enterer. We trained him in all of this data, and that's kind of great, right? Not that the PCR had much effect on the pandemic in Arequipa, but that some people are getting skills, so they're able to work in the Ministry of Health. We had the head of our wet lab went to the NIH and has been working at the NIH, and so we're losing people, and that's fine. I think the center's always been kind of an equal partnership with Peruvian PIs, and now I don't know. I think certainly Ricardo and Valerie are getting lots of grants and keeping the center going more than I am at this point. So I can fade into the I don't know what I'm going to do.
No.
Is that a personal question?
No. Thank you though for that. Are there any other questions for Mike? Let me see if that was just.
I will say, in the past, I've been very protective about U.S. students coming down for short periods of time. And that's from the experience of being in Lima, where Bob would have, in the summer, there'd be like 20 medical students for 8 weeks, and it was just a mess. And I think this year we're gonna be less strict and just like I'm just coming to see the brilliance of Bob would just say, "Come on down," and then people would show up, and some of them would not be great, and then every once in a while someone would stick around and come back, and I think in some ways that was good for everyone, even though there was this imbalance, that it was easy for US students to come there, and it's so much harder. I've had very few, we've only been able to bring students from Arequipa up for conferences. No one's been able to come to Penn for a PhD. And that's tough. And, I get told, write a training grant, as if that's the answer for everything. And we have training grants in Peru that or not we, but Cayetano does. Cesar and others have training grants that are training people in Peru. So it's, I'd like more back and forth. And so, yeah, I think Megan, I'll be less strict about people dedicating a year this summer if you have students who want to come down.
Okay. Yeah, thank you. Thank you for that. And slightly on that note, I know we're approaching time. So do you envision this partnership, as you said in your own words, kind of weaning less, I guess, on you and your research in Chagas, and more transitioning more towards an academic focus, more an education focus in bilateral exchange, similar to your parallel plagues course?
Yeah, that's where I'm more interested in working more with Cesar on education on both sides. Unfortunately, that's not how Penn, supports us faculty. So, wherever there is support for education, and then, luckily the MPH program has been very supportive, and that would be my look. And then, Ricardo's rabies work is just getting started. The Chagas epidemic we're almost done. I think there are very few bugs left. Definitely no new cases of Chagas from the bugs. Rest of the rabies is just emerging now. So I think the research side is going to move more towards rabies, and that, I'm actually thinking of how do I keep a core group of personnel. I think I need 4 people to run Alerta Chirimacha, and when we have bugs, to go to the houses and spray them. And so I just want to make sure I have the funds to keep them employed over time, so that it doesn't all fall apart. And I think that's very doable. I just need to get the model set up.
All righty. Thank you very much, Mike. And with that, if there's not any, other questions, I think we'll close today's session. Thank you again, Mike, for making the time and, discussing your partnership in Arequipa and, how it got started and what you're looking forward to and seeing its evolution through time. And with that, thank you. Everyone have a great day. Bye-bye.
I'll put my email in the chat if anyone.
Oh, yes, please. And we can disseminate that to folks as well. All right. Thanks, Mike.
See ya.
Bye-bye.